So my name is Dr. Krin, and I'm a lecturer at the University of Pretoria, Department of Neurology, and today I'm going to speak to you about states and disorders of consciousness. So we're going to go through the definitions of consciousness, coma and related states. Then I'm going to discuss the assessment of examination of a comatose patient. This will include the Glasgow Coma Scale, Neuroanatomy of Coma, Etiologies in Coma, as well as the neurological examination of coma and prognosis of medical coma. First, we're going to begin with consciousness. So consciousness is the state characterized by awareness of self and the environment, as well as the ability to respond to environmental factors. There are two components to consciousness. The arousal component, which is your level of consciousness. In other words, that which keeps us awake. Eye-opening, motor function. The other component is awareness. This consists of the psychological functions of sensations, emotions, and thoughts. And this is the content of consciousness. The physiology of consciousness requires an interaction between the reticular activating system of the brainstem, thalamus, and the cerebral cortex. So this RAS, or reticular activating system, is responsible for arousal. So the RAS projects to the thalamus and the cortex. It exerts both direct and indirect influences on the cortex. The cerebral cortex is responsible for awareness of self and the environment, the component of consciousness. So this RAS runs quite in the middle of the brainstem. And if you remember from my brainstem talk, this RAS system has bilateral projections to the cortex. Therefore, to get a disorder of the state of level of consciousness or a loss of consciousness, you have to knock the RAS out bilaterally. Now we're going to go through some important terms. The first is brain death. This is defined by death by neurological criteria. Coma is a state of unarousable unresponsiveness. It is a transient state. The vegetative state describes the patient to recover from the arousal component of consciousness, but not awareness. These patients will have what is called sleep-wake cycles. They will have no interaction with their environment whatsoever. A prolonged vegetative state for longer than 4 weeks in first world countries are described as the persistent vegetative state. If a patient goes into a vegetative state for longer than 3 months in first world countries, that's defined as a permanent vegetative state. The reason why the timing becomes important is because in certain countries, how the persistent state is defined is by different time lengths. For instance, in the UK, that state is of this permanent vegetative state is defined as 6 months. This next definition I want to talk to you about is the minimally consciousness state. These patients have severely altered consciousness, in which minimal but definite behavioral evidence of self or environmental awareness is demonstrated. While these patients don't have an emotional connection with their environment, they do have an interaction with their environment. For instance, they may track with their eyes, they may respond to pain, they may have responses to questions, although these answers may not be appropriate. But again, the significant thing here is they don't have an emotional connection with their environment, but they do connect with it. And that's the big difference between a minimal consciousness state and a vegetative state. An important concept to understand is that people transit between these states. So patients may go from consciousness to delirium. Then they go from consciousness to coma. Then they may go from coma to the vegetative state, and they even transition to the minimally consciousness state, back to consciousness. So these states are transitive. The final pathways in this processes are progressing from coma to brain death, or from coma to the vegetative, to the persistent vegetative, or even the permanent vegetative state. So these are all end stages of consciousness. As we go from coma to delirium to minimally consciousness states, we have an increasing amount of awareness. So important terms that you want to be aware of is the locked-in state, which describes the condition of total paralysis below the third nerve nuclei. Patients can open their eyes and can move their eyes up and down to command. The diagnosis depends on identifying that a patient can open their eyes voluntarily. Neuropathological basis for this condition is usually an infarction of the ventral pons and affects the efferent motor tracts. Other conditions include central pontine myelinosis, pontine hemorrhages, and tumors. It is very important when diagnosing the comatose patient to examine their eyes and ask them to follow commandments with their eyes. to rule out the locked-in state. Another incredibly important topic is psychogenic coma. Patients typically have tightly closed eyes and resist eye opening. They have intact normal caloric responses. They have normal inconsistent motor examinations. Their EEGs are typically normal. And one of the two tests that you want to perform on patients when you suspect are being in psychogenic coma is the hand drop test. You raise the patient's hand and you allow it to fall. If there's any delay in the fall, that may indicate psychogenic coma. That is, that the patient is feigning their coma. Another important test in this case, which is very caustic to the patient, is something called the nose hair tickling test, where you actually take an object and you tickle the patient's nose hair. People are very sensitive to this, and it's a very good identifier for people who are maybe feigning their level of consciousness. Another important term that I want to mention to you, which is very closely akin to the vegetative state, is akinetic mutism. This is characterized by abulia, a lack of spontaneous movements and eye closure. These patients have eye tracking, facial grimacing, blinking to thread, sleep-wake cycles, which can be based upon eye opening, and it's very similar to the vegetative state. The one difference here is, typically in the vegetative state, patients develop spasticity, and in akinetic mutism, they have flaccid paralysis, and this is typically caused by lesions in the cingulate gyri. So these are more important descriptive terms, essentially listed in a classical book by Plum and Poser about consciousness. These are the descriptive terms, and they are very important. Stupor patients appear to be asleep, but when vigorously stimulated, they will become alert. It is manifested by eye opening and ocular movements. Speech and other movements are limited. Obtundation happens when patients have mild to moderate reduction in alertness with a decrease in interest in the environment. Patients are slow in their responses. They also have an increase in the number of hours when they sleep. Clouding of consciousness. This is your delirium state. This is the state of reduced wakefulness or alertness characterized by hyperexcitability and irritability, with irritability alerting with drowsiness. Patients may be easily distracted and startled. It is characterized by misjudgment of sensory perceptions, and that's an important part of clouding of consciousness, which is akin to the delirious state. Somnolence and lethargy are talked about, and essentially they mean that the patient is sleepy. Now I'm going to touch base on the Glasgow Coma Scale. It's important that you know how to calculate this scale, as the Glasgow Coma Scale is an objective measure of arousal and uses 3 markers for consciousness. So I'll start with eye opening, which is based on a 4-point scale, either spontaneous, to speech, to pain, or none. And then we have motor functioning, either obeying commandments, localizing commandments, withdrawing from pain, abnormal flexion, extension, response, or no response to noxious stimuli at all. And then we have verbal functioning, where the patient's orientated, the patient is confused, such as a delirium stage, which we just mentioned, the patient is inappropriate but interacting with you, and then the patient is incomprehensible, and finally, when there's no interactions whatsoever to stimulation. The Glasgow Coma Scale is a reliable way of objectively monitoring the clinical cause of a patient, the acute cranial insult, without elucidating the cause. I will just mention there are more contemporary extensive coma scales called the Full Outline Unresponsiveness Scale, or the 4-score scale, which right now is probably not the standard of care, but it's coming more obvious, and this scale uses a similar scale to the Glasgow Coma Scale. I think it's good for you to know that this scale is out there, and we're most likely going to use it much more in the near future. Now I'm going to talk about the etiology of coma, which results from the toxic effects of various substances on our neurons, or from diffuse bihemispheric or brainstem damage, or compression of the brainstem structures caused by increase in intracranial pressure. Remember, you have to affect the RAS system bilaterally. Common causes are metabolic derangements such as high calcium, high sodium, thyroid storm, anoxia-hypoxic brain damage, where there's a decrease in the amount of blood oxygen to the brain, affecting that RAS system in both sides. Infectious causes such as meningoencephalitis, status epilepticus is also important to note here, is that non-convulsive status epilepticus is a common cause of coma. Trauma from diffuse axonal injury, again, we'll mention psychogenic unresponsiveness as a common cause of the unresponsive patient, and structural causes such as mass lesions in the brain, which can lead to herniation syndromes, which I'm going to talk about in a second now. So looking at the neuroanatomy of coma, a direct injury to the brainstem at or above the level of the pons might result in coma, but this requires that the injury occur rapidly and is of sufficient size, such as this hemorrhage that we can see here in the brainstem, which occurred rapidly. A slow-growing lesion near the brainstem may not result in coma. So an interruption between the reticular activating system and the cortex, such as bilateral thalamic infarcts, where you can see the infarcts involving both sides of the thalami that interrupts the direct connections from the RAS to the cortex, may also result in coma. So this infarction is caused by the classical example of an artery of Percheron infarct seen at the top of the basilar artery. And then most commonly an anoxic injury, as seen here in this patient, which results in severe bilateral disturbances of the hemispheric functioning, which will produce coma. So anoxic injury is seen here, and you have your typical findings on your head CT. That is where you have this loss of gray-white interface junction, diffuse swelling of the brain with loss of sulci, and things that can also cause bilateral disturbances of these hemispheres obviously include drugs, metabolic diseases, as well as status epilepticus. And this causes both the depression of both sides of the cortex and the reticular activating system. This can also be seen in severe brain trauma, where you have diffuse axonal injury, which resulting in severe injuries to the cortex. And again, you will see diffuse injury with both loss of gray-white structures as well as brain swelling, which is associated with a loss of sulci. So a unilateral hemispheric lesion, such as seen in this patient with an epidural hematoma, will not result in coma unless there is secondary brainstem compression caused by herniation down into the reticular activating system, or mass effect causing impairment of the opposite hemisphere. This lesion will result in a decrease in consciousness, and as the lesion grows, potential mass effect on the brainstem or contralateral hemisphere. You need one or the other to have a significant decrease in level of consciousness. So I'm going to go through some herniation syndromes now. The first is central herniation, which is downward herniation of the hemispheres and thalamus onto the midbrain, causing mass effect on that RAS. The second is uncal herniation. This is a downward herniation of the temporal lobe of the brainstem, also known as the lateral herniation syndrome. Again, this is lateral mass effect down on the brainstem, affecting the reticular activating system. This may also result in a third nerve palsy, which, if you may recall from efferent neuroophthalmology, will result in an initial pupillary dilatation before the somatic motor component is knocked out. This can then be associated with paresis of the ipsilateral to the lesion, termed as Kernohan's sign. The next herniation syndrome, which we're going to talk about, is subfalx herniation or cingulate herniation. This typically results from an anterior cerebral artery infarct or mass lesion, causing herniation across the top of the brain, causing midline pressure on the opposite side, resulting in a decrease in consciousness. This may also result because of its location in the occlusion of the contralateral anterior cerebral artery, resulting in a contralateral anterior cerebral artery stroke. This last set of herniation that I'm going to talk about is cerebellar herniation. This includes the cerebellar tonsillar herniation, which is a downward herniation of the cerebellum onto the medulla into the lower brainstem, or you can have an upward cerebellar herniation syndrome, resulting in compression into the midbrain. This is usually typically caused by mass effect lesions in the cerebellum, which can do one of two things. One, they can either just cause herniation themselves, or they can cause an occlusion of the fourth ventricle, resulting in hydrocephalus and central herniation. So the assessment of coma is an acute life-threatening situation. The initial evaluation must be rapid to prevent injury. Okay, so as always, you're going to do your ABCs. You're going to protect the airway, check for circulation. You want to make sure that the patient's blood is adequately oxygenating. You're also going to do initial blood samples for glucose, electrolytes, arterial blood gas, liver function tests, thyroid tests, as well as a full blood count and toxicology screen. Then he'll do your neurological examination. You'll try to localize the lesion. And then if you suspect that there's an increase in intracranial pressure, you have several options. You can do hyperventilation, you can use mannitol, or you can use hypertonic saline. In addition, you're going to want to give thiamine, always followed by glucose. This is incredibly important that thiamine precedes the administration of glucose, as this can cause a venous encephalopathy. Then if you want to try and reverse the patient for an accidental drug intoxication with naloxone for narcotic abuse or flumazenil for benzodiazepine use. Followed by gastric lavage of activated charcoal for other poisonings. Following these interventions, and probably at the same time, you're going to want to do a head CT scan to see if you can find structural causes of injury resulting in coma. Following these initial assessments, then you want to do more detailed and systemic examination. And based upon this, you may consider an EEG, looking for status epilepticus, particularly non-convulsive status epilepticus. You may want to perform a lumbar puncture, again looking for an infectious etiologies for this patient's depressed level of consciousness. This again is followed by a head CT to make sure that there's not a large, massive lesion accounting for the patient's changing level of consciousness prior to performing an LP. So it's important to always perform that head CT before you perform that LP, because otherwise you might be just missing that mass lesion. And when you perform the LP, you can precipitate a herniation syndrome. And then finally, if it's necessary, an MRI for a non-emergent situation. It may also help you with the diagnosis for this patient's coma, once the patient is obviously stabilized. So your general examination will include a general look at the patient, both for systemic causes of their injury and then a complete neurological examination looking for stuff like meningismus, a fundoscopic examination looking for evidence of intracranial pressure, head and neck exam to further look for injury or traumatic injury. You're going to want to look into the ears and make sure that you don't see any blood to identify traumatic brain injury. You want to do your level of consciousness for the Glasgow Coma scale. You're then going to want to follow up the motor responses to see if the patient's actually following commands, deeply in the reflexes to see if the patient has reflexes, check muscle tone and plantar responses. And then the most important exam in the coma patient is the brainstem function. You're going to assess for pupillary responses, spontaneous eye movements, the oculocephalic or doll's eyes response, the caloric responses, as well as corneal responses. The respiratory pattern of the patient in a coma may also help you to identify the cause of the patient's coma. I will talk about this more in detail in a second, but we're going to talk about Cheyne-Stokes breathing, central neurogenic hyperventilation, as well as apneustic breathing. But first, we're going to talk about the pupillary responses. So the pupils are very important with helping you to localize the lesion. Position. Midpoint position fixed pupils will indicate a midbrain lesion. Large fixed pupils will likely indicate a tectal lesion. Pinpointed pupils will indicate a pontine lesion. Fixed and dilated pupils, either bilaterally or one present in one eye only, may indicate or localize to a third nerve palsy. And then finally, small reactive pupils may indicate a diencephalic injury in patients with coma. So the breathing patterns that we just spoke about are typically as follows. So with Cheyne-Stokes respirations, it includes a crescendo-decrescendo pattern followed by a brief pause, then again a crescendo-decrescendo pattern. This typically indicates bilateral cerebral injury. Behatz breathing or cluster breathing, which is rapid breathing followed by a pause, indicates a medullary lesion. Cosmal breathing, which is essentially just rapid breathing in a patient with coma, may indicate a metabolic injury, particularly diabetic ketoacidosis. Apneustic breathing, which is essentially a long breath followed by a long pause, and then a long breath followed again by another long pause, it typically indicates a pontine lesion. This is typically mimicking something like ventilator breathing patterns. And finally, we get ataxic breathing. That is this chaotic breathing pattern of different amplitudes, which may indicate a medullary lesion. So prognosis in medical coma is our next topic. Why is a prognosis important? It's important to identify that those patients whom prognosis is hopeless and in whom persistent resuscitation and treatment is inappropriate. This came about by the advent of CPR in the 1960s, where intensive care medicine created the need for techniques to identify prognosis early in coma, so that patients would not remain in a persistent states of coma and persistent vegetative states unnecessarily following cardiac arrest or trauma. Just a couple of important topics in this area. There's a clear difference between the causes of coma, and that is patients with hypoxic ischemic causes of coma and coma caused by cerebrovascular disease accidents are unlikely to recover, whereas those patients with metabolic causes of coma are more likely to recover or survive their injuries. Again, the absence of cranial nerves is incredibly important in the prognosis of coma, and the absence of pupil, the pupillary response, corneal and oculocephalic or oculovestibular responses in most patients in these states of coma either end up dying or remain in the persistent vegetative states. So the next important topic are the outcomes of coma, which is based on Levy's study and its work in the 1980s on outcomes at 1 year in patients with non-traumatic coma. This also did not include people who are involved in drug overdoses. These criteria are basically based on people following cardiac arrest. The criteria are based upon a good outcome, where a person is independent but unable to resume prior state of activity or better, or poor, that is when the patients are either dead or in a persistent coma or vegetative state. So I just want to point out to you two things that on this chart that are incredibly important that I've used over the years. One, on the initial examination, absent pupillary responses in an overwhelming number of cases led to a poor outcome. That's 94% of the patients. 0% of those patients had a good outcome in Levy's studies. At 7 days following anoxic coma, any patient who is obeying commandments, a majority of those patients had a good outcome, and a very small percentage had a poor outcome. Finally, a poor outcome was almost 100% certain in Levy's data when patients were not following commandments at 7 days following hypoxic coma. So this work was further expanded by Dr. Etiologies in the 2000s. And Dr. Etiologies essentially reviewed all the outcome studies and found several important facts. One, a lack of brainstem reflexes at any one time, almost 100% of the time, indicated brain death. On further testing, the presence of myoclonus status epilepticus, that is an EEG pattern and examination consistent with this disorder, almost 100% of the time predicted a poor outcome. The absence of SSEPs, or somatosensory evoked potentials, from day 1 to 3 in these studies, almost 100% of the time predicted an poor outcome. An elevation of serum neuron-specific enolase of greater than 33 micrograms per liter also predicted a poor outcome. And finally, just reiterating the importance of pupillary responses at day 3, an absence pupillary response or an absence of motor responses again indicated a poor outcome. So as for outcome goes, there's been one significant change in the last several years, and that's the development of hypothermia after cardiac arrest. So patients found in the field or in the hospital in cardiac arrest is then put into a hypothermic program. That is 24 to 48 hours of hypothermia. This hypothermia is mild, 32 to 34 degrees. This is the only therapy which has been shown to improve the outcome in randomized controlled trials. So patients, no matter what their pre-existing coma scale was, when put into hypothermia had an improved outcome than patients who weren't put into the trial. 1 in 6 additional patients had an improved outcome, and this is a significant number. There are multiple mechanisms of action for hypothermia. In this case, it is actually relatively safe. The biggest risk factor is infection, and is but it's still currently recommended by the American Heart Association and is considered to be standard of care for witnessed out-of-hospital cardiac arrest patients. There are reports of patients recovering after poor prognostic signs which have been identified, including the absence of pupillary responses. There's also been one case reported where the use of hypothermia in a patient was essentially diagnosed as being brain dead and also subsequently had a recovery. So I just want to mention that there are some evidence in the hypothermia is worthwhile. There are also case reports of extremely unusual outcomes following hypothermia. So I just want to thank you for your time. That was my last slide.